Hello, this is the seminar on fluid and electrolyte management in children. So the aim is to help you understand basic principles of prescribing fluids in children and fluid resuscitating children who are dehydrated. Okay, so to begin with, we'll go through some basic rules and then we will try out some examples. Okay, so let's look at the rules. So there are a couple of ways you can calculate fluid. An easy method is the 150-20 rule and the 4-to-1 rule. So let's assume a child is 30 kilograms in weight. So for the first 10 kilos you would give 100 per kilo, so that's 1000 mils. For the next 10 kilos you would give 50 mils per kilo, so that will give you 500 mils. And for anything afterwards you would give 20 per kilo. So in this particular example there's another 10 kilo left, so that will give you 200 mils. So that's a grand total of 1700 mils for the whole day, and you obviously, if you divide it by 24, you get the maintenance. Now the easier way of doing it is the 4-to-1 rule. So again, in this particular example where the child's weight is 30 kilograms, so the first 10 kilo would give you 4 mils per kilo, so that's 40 mils. The second 10 kilos would give you 2 mils per kilo, so that's 20 mils, and anything subsequent to that would be 1 ml per kilo. In this case that will be 10 ml. So if you add that all up, you get 70 mils an hour. So you could try out a few on your own to see if you get the hang of it. Okay, so the next thing is to calculate dehydration. So let's look at the same child again and assume this child is 10% dehydrated. So if the child is 30 kilograms and is 10% dehydrated, that will be 3 kilograms of fluid lost. So 3 kilograms of fluid would be 3000 mils of fluid, and you would replace this over 24 to 48 hours depending on the urgency. Now remember, this dehydration you will have to add on top of the normal maintenance which we calculated using one of the rules above. Okay, there's an easier way of doing it. The formula for that would be weight times percentage dehydration times 10 in this particular instance, times 10. So in this particular instance the weight was 30 kilograms times percentage dehydration was 10, so that's 30 times 10, so that gives you 300, times 10 again, so that gives you 3000, and you would replace that 3000 mils over 24 to 48 hours. For example, if you want to replace it over 48 hours, you would do 3000 divided by 48, and you would add that to the maintenance fluid that you calculated above. Now assessing the dehydration, it's pretty straightforward. 10% is your lethargic child with prolonged capillary fill, tachycardic and in shock, and 3% is your mild dehydration with just a dry mucous membrane, and the moderate dehydration is 5%, which is everything in between. So let's look at a few examples now. Hello, testing. So the first example is a 7-year-old girl who is admitted for elective surgery. So she's not dehydrated, so she is just kept nil orally. Her weight is 23 kilograms. So can you write an IV fluid order for her prior to her surgery? By the looks of it, she's going to be nil by mouth for 24 hours. Right, okay, so how do we do this? So let's do the 150-20 rule. So for the first 10 kilos you get 1000 mils. The second 10 kilos you get 500 mils. There's 3 kilos left after that, so that's 20 per kilo, so that's 60 mils. So 1000 plus 500 plus 60, so that is 1560 mils is the total fluid this child will need in 24 hours. So per hour would be 1560 divided by 24. how would you prescribe it? So you would the standard fluid which we use in this hospital is 0.45 sodium chloride and 5% dextrose. So you would obviously put the date in, and where it says type of fluid, you would write 0.45 sodium chloride and 5% dextrose. The volume, you would say the bags are usually 500 mils. You can also get liter bags, so you would say 500 mils there. Additives, so normally if someone's going to be on fluids for more than 24 hours, you would put them on 10, you would add 10 millimoles of potassium chloride to a 500 mils bag, so you would do that. And then your rate would be 1560 divided by 24, that many mils per hour would be your rate, and then you would sign and put your initial and bleep number there. Okay, so hope that's clear. Let's move on to another one now. So let's look at another case now. So this is a 2-year-old child who has sustained a head injury, and he's 14 kilograms. So what are the factors which you need to consider when you're calculating fluid for this child? So it's a head injury. Obviously you don't want to increase the intracranial pressure any further. So the sort of general rule is to restrict them to 2/3 maintenance or half maintenance. How would you do that? It's very simple. So you would calculate the fluids as you would normally do. So for 14 kilograms it will be 1000 for the first 10 kilos and 200 mils for the next 4 kilos. So that's 1200 mils. You divide it by 24 and then you get the mils per hour. So if you want 2/3 of it, so you got the 1200 and then you take 2/3 of that, so that will be 800 mils. So that's how you would calculate the fluid requirement. Some clinicians might want to restrict them even further to half maintenance, in which case you would just take 600. What's the type of fluid you would use? So the main thing to remember is saline is isotonic, so you want to use at least isotonic solution. So I would use 0.9% sodium chloride, and you would add dextrose if required to that. Try to avoid hypotonic solutions like 0.45 or 0.18, especially in this situation, because you might make the cerebral edema worse. Okay, so how would this differ from a child with high temperature and tachycardia? Obviously in high temperature and tachycardia you are thinking more about a septic child or a child who has got a fluid deficit, in which case you would actually give a fluid bolus to begin with. Whereas in a head injury you would maintain the blood pressure, but you would try and avoid fluid boluses if possible. Okay, let's move on to the next one then. So here we have a 10-month-old infant who's got diarrhea and vomiting and low-grade pyrexia. So your diagnosis is viral gastroenteritis, fairly common. How would you decide if you want to give IV fluids or not? Generally you try and avoid IV fluids if possible in these situations, and use that only when you fail a enteral fluid challenge. Now when I say enteral fluid challenge, you would assess for dehydration. If it's mild or moderate dehydration or no dehydration, you would carry on giving some oral rehydration solution. It's called diarrhoea in general, and that's basically that basically contains sugar and salt, and obviously you decide it in set amount of water. It's better than water because obviously it has the salt and the sugar, and that's likely to be more absorbed, and when it's absorbed it switches off the ketone production and then you're less sick. So that's the preferred fluid, and I would try and avoid plain water or diluted juice if possible, but it's not always possible because some children would refuse to drink diarrhoea. Right, okay, so how would you give diarrhoea? So this child is probably 10 months old, so it's going to be 9 kilos or so in weight. So you want to give sort of small amounts, 9 to 10 mils or so every 5 minutes in a little syringe. If you give small amounts, it's more likely to be absorbed, the child's less likely to be sick. You keep reassessing them. If the child's passing urine and it's the dehydration is not progressing, then you would stick to your plan. If the dehydration is getting worse and if the child is not keeping it down, then you would want to consider putting an IV cannula in and giving some IV fluids and correcting a dehydration as usual. Right. So case number 4, an infant's 11 kilograms and is 10% dehydrated. What is the calculated fluid deficit and how should it be replaced? What IV solution should be used? What lab test should be done? So it's 10% dehydrated. Child's nearly in shock probably. So this child, you probably will find that has got a prolonged cap refill, is very tachycardic, skin turgor might be reduced, mucosa will be dry, there won't be any tears, child might be a bit lethargic. So you want to treat it aggressively. So if the child has signs of shock, then obviously you want to give a fluid bolus. So fluid bolus is always normal saline, 0.9% sodium chloride. So we would usually use a bolus of 20 mils per kilo. So in this child it will be 220 mils. You would give it as a fluid bolus, and then you would calculate the fluid deficit. So this child's 10% dehydrated, so that will be 1.1 kilograms, which will be 1100 mils. So this child has a deficit of 1100 mils, and you want to replace it over 24 to 48 hours. So you would, if you would decide to replace it over 48 hours, you would do 1100 minus the 220 bolus you've given, divided by 48. So that will give you how much you need to replace over 48 hours. That will give you the hourly rate. Remember that you have to add your normal maintenance to it. What IV solution? Again, for bolus you would use the saline, 0.9% saline. For maintenance you would use 0.45 saline and 5% dextrose. What are the lab tests you would do? So this child depends on the cost really. If the child is septic, you would do a septic workup, but the main thing is to make sure that you check the electrolytes, check the urea, check the creatinine, check the hematocrit, because it's a small child, so you would do all that. Right. Okay, let's look at another one. A 3-month-old is brought to A&E with multifocal seizures lasting a few minutes. He's had a history of diarrhea, and mom was largely feeding water and orange juice. So what does water and orange juice contain? Obviously it doesn't have a lot of sodium. I'm not sure if it's particularly rich in potassium. Orange juice, it might be, but certainly doesn't have enough sodium. So the cause of seizure might be low sodium hyponatremia. So that sort of is a slide to actually emphasize the importance of using diarrhoea rather than water or juice in especially in young infants who are dehydrated. And the main thing to bear in mind is, if you're correcting it, you don't want to correct it rapidly. If it's a lot of sodium, you want to correct it gently. Okay, right, let's move on to the next one. So the next one is a 9-month-old infant who has diarrhea and signs of dehydration. The sodium is 162, potassium is 5.6, so pretty high sodium. Bicarbonate is 12, which is low. You're in charge, you're doing IV rehydration, and the patient's gone into a generalized tonic-clonic seizure. So what's the cause? What's the probable cause for seizure? So we discussed earlier that any electrolyte imbalance should be corrected gently. So if you have a sodium of 162, and if you have given, for example, 0.18 saline, that's going to crash your sodium down very quickly. So the rapid decrease in sodium can cause destruction of the myelin and can cause seizures. So it's very important that we don't do that. So in this situation we would tend to use at least 0.9% saline and make sure that the sodium drops very gradually. So in this particular case of hypernatremia, you would treat them with 0.9% saline, although it might seem a bit counterintuitive. Right, okay, let's move on to the next one. So this is 11-month-old infant who has vomiting and diarrhea. She is lethargic, she has dry mucous membrane, heart rate is 130. She passed urine 6 hours ago, so sort of moderately dehydrated. What type of fluid would you recommend that her mum give to this infant, and how often? I think we discussed this already. You would use diarrhoea, and you would use 1 to 2 mils per kilo of diarrhoea every 5 minutes or so. Keep a very close eye on how much the child's taking in. If the child's sick or if the child's having a dirty nappy, you would weigh that. Make sure that you maintain an input-output chart. Reevaluate them periodically, and if things are not going well, then you would go for an IV rehydration. Now let's look at this one. This is a very important slide. So you have a 7-year-old boy with newly diagnosed diabetes, and these are his blood sugars. Usually in children, vast majority, almost all, have type 1 diabetes, unlike adults. So BM, the blood sugar is 26, so it's very high, so it's in the DKA range. Ketones are 4.1, again in the DKA range. Sodium is 132, slightly low. Potassium is 5.4, slightly high. Bicarbonate is 9, so it does fit the criteria for DKA pretty much. You want to know the pH as well. What fluid should be used over the course of his DKA management? So thing to bear in mind is initially they're very dehydrated, so rule of thumb is if you're very sick, use saline. So you would use saline to begin with to rehydrate him, and as you rehydrate them and as the sugar drops, you would start insulin to begin with, and when the sugar drops, you would keep an eye on how quickly the sugar is dropping, and if it's dropping quite drastically, rather than cutting down on the insulin, what we tend to do in children is actually add some dextrose to the fluid, because they need the insulin to switch the ketone production off. As the fluid deficit is corrected, all the potassium which has been intracellular in DKA, they usually come out of the cells and extra, they are sort of in the intravascular compartment. So the potassium, as you can see, was spuriously high to begin with, but as you correct the DKA, all the potassium would go back where it belongs, which is inside the cell, which will mean that your serum potassium would drop. So you have to make sure that you add enough potassium into your rehydration correction bags, otherwise your potassium might drop very rapidly. So we discussed how this should be managed already. Okay, so we move on to the next slide. So this is a 15-month-old girl who presented with 2-day history of diarrhea and vomiting. She's listless and her heart rate is 180. Now clearly this is a listless child, not just a miserable child, and heart rate is very high, so this will fall into a category of severe dehydration. So you would straight away cannulate this child and give some resuscitation fluid at 10 mils per kilo, sorry, at 20 mils per kilo, reassess and take it from there. So hope I've given you a flavor of how to manage fluid in children. The best way to do it is actually when you come around to the ward to have a look at the fluid prescriptions, and then speak to the doctors in the ward to see the reasons behind the prescriptions, and it's a lot easier than you think it is. Initially it might be a bit daunting, pediatric fluid prescription, but with practicing a few, it becomes really easy. Thank you.